Ok, boa tarde, sejam bem-vindos. Hoje a nossa sessão, mais uma vez, é com convidados internacionais. E a gente vai ter o prazer, mais uma vez, de ter o professor Mike Rigby, professora Ian Hu, lá do Brompton, professora Vera Aiello, de São Paulo, professora Catarina, da nossa equipe, aqui em Recife. Vamos conversar um pouquinho, e a gente está mantendo mais inglês, né, gente? Mas acho que todo mundo tem gostado e tem aceito. I just said thank you to everyone, and I said that people are getting used to the fact that we're using more English in our sessions, and I think we'll just go in English. If anyone wants to ask a question in Portuguese or something, we can translate and go on. So we saw the little teaser, and this case comes from the Royal Brompton Hospital. Professor Mike Rigby sent it to us, and he will talk a little bit about this child and present us the information on this child. Michael, thank you again for being here and helping and sharing with us.
So this is a new case, in fact, to us of tetralogy of Fallot that turned up the other day. Completely well and symptom-free, no cyanosis, a long systolic murmur, best heard at the mid-left sternal edge. And in fact, you can split the second sound, but basically a diagnosis of tetralogy of Fallot was made by a member of our team. I had noticed that the echoes looked rather nice, and I was looking back at the study, and a couple of things I noticed that actually had been missed. One of them was that you might have noticed at the beginning that the ventricular septal defect is rather small. And in fact, the gradient between the left ventricle and the right ventricle was 50 millimeters of mercury on Doppler. And you'll notice, so there we are. There's a picture, like a subcostal outlet view. You'll notice you can see the small VSD at that point. It looks a bit small for a tetralogy of Fallot. And when we get to the parasternal or apical long axis view, you will also notice that the aorta arises virtually entirely from the left ventricle. So there's not any override, which of course sometimes occurs in tetralogy. There is no override, but you'll also see here the ventricular septal defect does look rather small. I probably didn't send the Doppler of the gradient, but it was 50 millimeters of mercury. So it'd be interesting to hear what the morphologist take is on restrictive VSD in tetralogy, which is relatively rare, in fact, but we see cases occasionally. Well, we'll probably stop there, sure. But the other thing that we happened to find, I don't know whether you've got, was I noticed that there was an anomalous origin of the left anterior descending coronary artery from the right coronary artery going across the outflow tract of the right ventricle. I don't know whether that shows up, but that was, in fact, what we did find there were dual LADs, one normal LAD and one rather large LAD from the right coronary artery. And the cardiac surgeons, the morphologists will tell us the significance of that. Look at this beautiful subcostal right oblique projection, which shows the relatively mild infundibular stenosis. You can see the bifurcation of the pulmonary arteries, and you can see the pulmonary valve itself opening and closing. So it's not surprising that on auscultation, you can actually hear pulmonary valve closure. So mild pulmonary stenosis, mild infundibular stenosis, restrictive VSD, tetralogy of Fallot anatomy.
Mike, could you comment on the extension of the outlet septum in this case, please?
Well, in this subcostal right oblique view, we do see like the teardrop outlet septum, don't we, hanging into the right ventricle in fairly normal fashion. So at a glance, you may not think that there was a restrictive VSD. And then at times during the cardiac cycle, you can see there's kind of some muscle going across underneath the aorta, and you can see showing that it is a restrictive VSD. This is not the ideal view to show it, but you do see the outlet septum there, infundibular septum, hanging free also in the right ventricle. So maybe the morphologist should tell us about restrictive VSD in tetralogy.
I think they're very rare. I can't remember seeing one.
Have you seen one, Vera?
I'm afraid not. Not like this one, so restrictive. No. Yes, and I was wondering if the extension of the outlet septum would be, you see, because some measurements made by Tom Becker some decades ago described the very long infundibular septum, and in this case, for me, I'm not an echo specialist, but for me, the infundibular septum or outlet septum seems not short. I don't know what do you think?
It is. I agree with you. It is a short septum, no doubt about that. Yes. Yeah.
I think it may be short septum, but it's the angulation of the septum that's causing the stenosis more than anything else. And then you see the muscle bundles across the other side of the right ventricular outflow tract. Those are the septoparietal trabeculations, very hypertrophy, adding on to the obstruction.
In reality, this particular case for a cardiac surgeon looks easier than the average tetralogy, because the aortas are rising from the left ventricle. They just have to close the VSD, relieve a bit of take some of the muscle bundles out of the right ventricular outflow tract, and probably get a very good result. But some of the restrictive VSDs I've seen have been caused by one tricuspid valve tissue, partly obstructing the defect. And the other type that we see, Vera and Yen, is where the aorta arises almost entirely from the right ventricle. And therefore the gradient across the VSD between left and right ventricle occurs at the almost like the left ventricular infundibular fold. We've seen that. Sounds like these patients don't die.
They don't die, that's the point. So they don't come to us.
Yes, that must be it, mustn't it?
Yeah.
Because I've seen a few over the years, you know, obviously not one, not regular, over the years. Yeah. So I think in this case, however, it doesn't make too much difference because the repair is almost easier than it might usually be.
Apart from the anomalous coronary artery causing in front.
Yeah.
I don't know whether I've sent the echo, well, I tried to, but it may not be showing this very well. It's the short axis view of the aorta. Maybe it didn't arrive. But
let me see if it's here. I'm just looking to see if it hasn't been added here. Okay. Okay, perhaps you have the image here.
I can show you this. I'm just going to, I'll try texting it to you. Give me a moment. Give me one moment.
Okay, let me see. I think I can share it here. Okay, just 1 second, and I will move on.
I think the picture I've just sent you is the one. If it's moved, when it moves, it hasn't come yet. So I sent it.
I'm just trying to change it to new one here. This one, and okay, this is the one. You see that? Yeah.
Okay. When you're looking, Helen, at if you have a case of, in your hospital, tetralogy fellow, but with pulmonary atresia with pulmonary atresia, so tetralogy type anatomy, pulmonary atresia. Well, there's the anomalous coronary there. You can see the right coronary, that rather big, quite a big vessel, and then it just keeps playing. Play it again, and then you'll see something going across above the aorta, and that's it. There it is. That is the LAD going across from almost like 9 o'clock to 3 o'clock, going across the right ventricular outlet. There it is. That's it.
Yeah.
So you can see it there absolutely beautifully, going across what will be the ventricular arterial junction, exactly where the surgeon would make his incision if he was going to make a right ventricular incision, which often they would, particularly say in this case, if he wanted to do that, a small incision to resect some muscle, he would have to cut through the coronary, and if the coronary artery was hidden in the myocardium, he might miss it, and that would end up, and then you'd end up with ventricular dysfunction and what have you. So it can be quite serious if it's not spotted.
But have you seen frequently these dual coronary LADs, or like in this case?
I think we do see it's not so it's frequent enough. I know when Elliot Scheinborn wrote a paper on the recognition of this with angiography, that they had a number of cases, if there were kind of 12 cases, they had half of them seem to have a dual LAD. So it's not so unusual to have a second, but obviously they supply different areas of myocardium, don't they? So if you cut one LAD, you still end up with some myocardial ischemia from some parts of the myocardium.
And can you, Sandra, can you please show me, at least for me, because I can't understand it really well, the echo, the second one?
So what you've seen there is there's.
Oh.
That's it there. So where the.
It's difficult to stop. I have to,
Difficult to stop. So above the aorta there, there's a view there which shows there.
Yeah, I managed to stop once before, but now.
That was quite good.
Yeah. No, yeah. It's just because it's a little bit extended.
It's kind of one of those, but it's pretty obvious. In that view there, you can just point out the right coronary artery.
So for there. Okay.
Yeah, that's the right coronary artery, and so that is the rather beefy right coronary artery, and I think. And then you just play that on a frame or two, you'll see coming from that is a blood vessel going across to about 3 o'clock. Yeah.
It's just hard to,
Yes.
Movement.
Once you note it, that's it. So that vessel going across the top, going to the outflow tract. But this is a short axis view through the aorta. That is it. Easy to miss, of course.
Sure. Yeah.
To miss. quite a lot of our patients these days, the surgeons ask for a CT to look at to make sure that the patient doesn't have an anomalous LAD from the right coronary. But
I find amazing the quantity of information you can get from the echo nowadays.
It is, yes. And I think the thing is, when this was recorded, the person recording the echo didn't realize there was an anomalous LAD and didn't linger on the picture very well. It was only when I was looking through it that even I recognized the LAD. So my vision is still reasonably good, thank God.
Very, very interesting. Yeah. So when you said about asking for further exams to look at the coronaries, is this becoming a more routine thing on echoes, or I mean, do you basically try to make sure that you have documented the 2 coronary arteries well, and if you have, you don't go further, but if not,
to be honest, in the surgeons have a very low threshold for asking for other investigations these days. And we have a pretty good CT service, very conveniently located, and because it's the acquisition time for a CT is very short. So the baby goes down for a CT, they've done it in 10 minutes. Whereas, for example, if you're going for an MRI, the minimum acquisition time is probably 35, 40 minutes. It might be an hour. Whereas, for a baby, you need a GA. Whereas for a CT, they can acquire it very quickly. So they get very nice pictures of the coronary arteries, providing the heart rate is not too fast. And if the heart rate is a bit fast, they just give some beta blocker just to slow the heart rate down a little. So the surgeons, they get. There's a lot of tetralogies are repaired now, but between the ages of 5 months and 6 months. So the surgeons like just to be certain the coronaries are normal.
I think it's interesting that you mentioned that, because Fernando, who couldn't be present today, he's away. But he has been more or less having this kind of same approach of having a very, very low threshold to ask for investigating these coronaries a bit better. Yes, doing the CTs. And I'm sure you will hear it say this.
You only need to be bitten once and find the LADs hidden in the myocardium, and you don't see it, So,
Mike, I have a question, please. I missed the beginning of the presentation because my connection was not good. I didn't see the other LAD. Did you show both LAD?
I don't think we did, but I don't think we did actually. But there is a very, I don't think I did, but on another clip, which I didn't send to you, though, with a short axis of the aorta, you can see the right coronary and the left coronary dividing into LAD and circumflex.
Okay.
So there was definitely a second LAD.
Okay.
A good question. No, we did see it.
Okay. I think this is a very important message for echocardiographists. Yes. Always to look for, wrong ways, wrong passages of coronary arteries on the outflow tract. But these images are very good, very, very good.
And this is not, when you say what are the coronaries like, you're not looking to see the coronaries are present or whatever it is. It's just to look for this anomaly, really. Obviously, occasionally we see a single right coronary or something, but looking for this anomaly, which is 5%. 5% of all cases of tetralogy of Fetal will have LAD from, when you probably have seen it as an incidental finding sometimes, haven't you, Vera?
Okay. And this child has had surgery?
Not yet.
Not yet.
Okay. He's a very pink, symptom-free tetralogy.
Okay.
So in the
How
next
old
month.
is the child? How old is
No,
the child?
6 months.
Okay, okay.
6 months.
Mhm.
So there's no urgency. He's on the routine list, I think. So it could be. Remember, it's our summer holidays now, August. So it could be in September.
Okay,
There's less routine operating in August.
right.
But you'd be doing the routine tetralogies, the tetralogies without symptoms, and okay, usually around the age of 6 months.
About 6 months, yeah.
Okay, so, okay.
The surgeons don't think it's any easier to wait till 9 months or a year. That's what they say.
It's the same here. Very good. I think
Good.
it's- Yeah, very, very good and very important message, as you say, Katerina, to make sure that, I think 2 things, make sure that you see, and if you don't see, don't assume that it's there, and have a low threshold to do the CT.
Have you got any pictures, Yen, of tetralogy and an anomalous LAD?
Mhm.
You can show us.
Yes, I put together a few slides if you want to see them.
Good.
It's great. I can show your screen now.
Goes without saying that this malformation is described by Fellow back in 1888.
Really?
And he called it the blue disease. In fact, the malformation had been described prior to that by a Scandinavian, but he didn't put them all together to make a blue disease, whereas Fellow did. And the components of this malformation are listed here: a ventricular septal defect, subpulmonary stenosis with overriding of the aorta, and consequently right ventricular hypertrophy. And this is a fetal heart that was recognized in utero as having Fellow's tetralogy. It is a fairly common congenital heart malformation, accounting for about 5% of individuals. So in terms of the right ventricle, obviously the whole focus of tetralogy of Fellow is on the right ventricle. So the repair is carried out in the right ventricle. These muscle structures that are within the outflow tract that cause the obstruction are highlighted here. We have the outlet septum, which is described as anterior and flat deviated, squeezing the subpulmonary outflow tract. And these muscle bundles are present in the normal heart, but they don't cause obstruction, whereas in Fellow's tetralogy, they become hypertrophied and cause more obstruction. And these are termed the septoparietal trabeculations, meaning that they come from the septum and they go across the outer side of the anterior side of the outflow tract to the other side of the ventricular wall. So septoparietal trabeculations. There is another muscle band that is adherent to the ventricular septum and does not usually cause problems, although in very few cases, it may become hypertrophied and give a sort of two-chambered right ventricle configuration, a septal marginal trabeculation called the septal band in North America. And over here, we have colored in green here, the ventricular-infundibular fold, which is basically the muscular structure separating an arterial valve, in this case the aortic valve, that is overriding the ventricular septum, peeping across here, separating aortic valve from the tricuspid valve. So here is the ventricular septal defect, and overriding this defect is the aortic valve. So the 4 features of Fellow's tetralogy are due to the configuration of the right ventricular outflow tract. So in closer up then, we can see this squeezing of the outflow tract caused by the deviation of the outlet septum. We say inserting into the anterior limb of the septum marginal trabeculation. if you take that stenosis to more severe degree, you can end up with pulmonary atresia, but with Fallot's tetralogy, outflow morphology. So if we take a normal heart and cut through the right ventricle, we see that there is no hole. In other words, no ventricular septal defect, ventricular infundibular fold between pulmonary and tricuspid valves. Fallot's tetralogy, obviously outlet septum, very much anterior capsular deviated. We make a cut in the heart, as we show you here, and open up the right ventricle. We can now see the aortic valve through the ventricular septal defect, the outlet septum cut through, so short axis through the outlet septum. We see that teardrop shape configuration, and the probe in the right ventricular outflow tract, or half of the right ventricular outflow tract, pointing to the pulmonary valve. So very, very severe narrowing of that outflow tract in this particular heart. The septoparietal trabeculations are here, lining the anterior wall of that outflow tract. Aortic valve peeping through, or with the aortic override across the ventricular septal defect here. We see attenuation of the ventricular infundibular fold, meaning that when we look at this heart, we see aortic and tricuspid valve fibrous continuity. So in this case, we have a perimembranous defect associated with this particular tetralogy of Fallot. And by the way, those of you who are sharp-eyed enough might have noticed this is a right aortic arch configuration. It's not a normal left aortic arch. So the arch goes to the right side of the trachea. It occurs in about 25% of Fallot's tetralogy. This is like your subcostal kind of echocardiographic cut. You see the outlet septum, quite a long teardrop shape, isn't it? But the thing is, the long axis of this teardrop is pointing into the outflow tract, and that's the substrate for subpulmonary muscular obstruction. And over here, the aorta, aortic valve, and the ventricular septum, again, a perimembranous VSD. So just play it a little bit. You see turning around, pull back the left, in this case, the left aortic arch, and pulmonary trunk up here, bifurcating. The meaning of overriding aorta can be demonstrated on this cut, a longitudinal cut through a heart. We see the aortic valve leading to the aorta. So the aortic valve is sitting directly above the ventricular septal defect here. This is the crest of the ventricular septum. So if you want to take the margins of a ventricular septal defect, it could be this border or it could be that border. But it is actually this border that the surgeon would put a patch in order to exclude the aorta from the right ventricle. So all the flow would come from left ventricle up to the aorta. And by the way, on more close-up view, you can see the cross-section through the pulmonary valve here. These are the leaflets of the pulmonary valve in this particular heart. So larger aortic valve overriding, smaller pulmonary trunk. And in this case, there was muscle separating aortic valve from the tricuspid valve. So this is the case of Fallot's tetralogy with a muscular outlet ventricular septal defect, meaning that the atrioventricular conduction bundle is that little bit further away from the immediate margin of the defect, relevant to the surgeon when the surgeon's putting the patch to close off the VSD. And I'll show you now two cases. This is the first case that have had Fallot's tetralogy repair. And we can see on the outside a patch extension across the right ventricular outflow tract, a homograft valve inserted, a ventricular septal defect closed, but I think I had sort of cut through some of the sutures to try and see what sort of defect it was. So in this particular heart, the repair was the transannular incision from the right ventricle into the pulmonary valve in replacement with a homograft. This is another heart that had previous repair. These hearts were from the archive, some that came into the archive maybe 20, 30 years ago. And this is the outflow patch. In here, again, a valve put in. And now the ventricular septal defect is no longer seen. In fact, you can hardly make out that there was a defect. This is, in fact, a patch, very well endothelialized, that had closed off the defect. Now, the importance of recognizing this kind of anterior course of an anomalous coronary artery is demonstrated on this specimen. So the surgeon had, in fact, made a hole in the right ventricle and put a tube graft across in order to avoid traumatizing this anomalous left anterior descending coronary artery crossing the right ventricular outflow tract. And this is another left anterior descending coronary artery. And because it's impossible to know which one is the more dominant or providing the supply to more areas of the myocardium and the septum, it's best to have both preserved. In this other heart, we have this left anterior descending coming from the right coronary artery. Here it is. And then it tucked itself intramyocardially before exiting again. So there was a kind of myocardial bridge. In this other specimen, there was a patch repair, and the surgeon also opened up the pulmonary trunk, trying to avoid the coronary artery crossing this area, but one of the sutures had actually caught that coronary artery. So here we are, the right coronary coming out. This is the anomalous artery crossing the outflow tract. There's a little suture there. And opening up the left ventricle. I'm sorry, it's a bit dark. And we can see how the anterior wall of that left ventricle had been affected. So it's much thinner now compared to its posterior inferior wall. So I think that's, for me, a short synopsis of lamellodid blue. Just to remind people, if you're interested in morphology of congenital heart defects made simple, it's an online course that's available on our website here. You can link in to us and check it out. Thank you.
This is great, Ian. Thank you very much. So good to revise and see so many important points about tetralogy. I would like just to put one question that regarding the case, Mike. But I think it will be interesting just hear your opinion. Okay, so I don't know. It's very
well, this is a good point. And in fact, yeah, but there was some stenosis across that subpulmonary area. Remember, the picture is quite kind of expanded. It's not, and there was a gradient. Well, there was a measured gradient, I think about 60 or 65 across it. So I think there was some subpulmonary stenosis, but it was mild, and there wasn't much anterior deviation. You're right, of that rather hypoplastic outlet septum, but there was some muscle bundles there. So I think it was a tetralogy of Fallow case. I don't have any doubt about that, but an unusual case. Well,
I think that's important just to make a clear definition of when cross line of tetralogy, and when to stop doing that. So what would be the key components that would be necessary to say, no, this is a tetralogy. I think this is VSD pulmonary stenosis and perhaps a little aortic override. So just for those who are listening to us, what would you
I know the examples of the coronary artery anomaly shown by Yen. She only knew she was taking part, I think, at about 2 o'clock. So she's done very well to get all those things together. Terrific.
Yeah.
I mean, it's a very nice example of dual LAD there, and the LAD going, you can see the potential surgical problems. It was terrific.
Yeah, that's very good. Yeah.
Yeah.
So anyway, our colleague Stu asks if it wouldn't be better to describe it with what valve stenosis was associated with BSD. I think there were more things into this, wasn't it?
Yeah, well, you could say this is a close cousin of tetralogy of Fallot if you wanted to, and there was mainly pulmonary valve stenosis, minimal muscular outflow tract obstruction, and the BSD was not large, and there wasn't really any aortic override, and therefore this is not, strictly speaking, a case of tetralogy of Fallot. Indeed, you could say that. You could say that. So it wouldn't be enough to fall out over, would it? You'd say a close cousin, if you want. But I'd still group it into tetralogy. Well, it's interesting that in my team, somebody diagnosed it as being a case of tetralogy. But I kind of agree.
Yeah. I think it's important is to, again, as you all have taught me, Jan and Vera and you, Mike, and all this, I think it's very important to describe detailedly what you have, what you're seeing, isn't it? So you may use the term or not use the term, but it's very important to have the description of every detail about the VSD, the presence or not of the infidulus.
Anyway, we've had a very nice discussion.
Yeah, very good. Absolutely. I must thank you all again for taking your time to be with us. I think we're revising things. We're learning a lot, and as I said in the very beginning, I think it's a great opportunity to be with friends and discuss and bring things forward. And I think the people that have been listening to us and the ones that are there thanking for the presentation, and look forward to our next meeting. I think next week it's probably going to be a fetal case, but we'll be here to be discussing, and you're all invited. It'll be very, very nice to have you all here again. Okay? Thank you.
Thank you. Thank you very much.
Bye, everyone. Enjoy the weekend.
Bye-bye.
You
Good
too.
Bye-bye.
Bye.
You too.
Thank you. Thank you.
Bye-bye.